All right, I think we can go ahead and start. It's 2 after 6. Good afternoon, good evening, everyone. Thank you so much for joining us today. My name is Ajwa Osei. I'm with UCR Health, part of the AAP Chapter 2 on the ACES Committee. And I join the rest of the team in welcoming you all to tonight's session, where we are running a peer-to-peer learning series in conjunction with First 5 LA. Today, we will be going through a few things. This is a continuation of the series we've been running about ACEs and how to get it going in our practices. So I'm going to be with you tonight, walking you through things, and I will be introducing the speaker as we move along. All right, so this is just a brief overview of how our evening is going to run today. We will be hearing from Dr. Carlo DeAntonio today, and he will be talking about building ACEs, response, interventions, and overcoming barriers to referrals. And then after that, we're going to go out into our breakout sessions where we'll have some discussions. We're going to come back after that and report out and share what we talked about to the larger group. And then we hope to close everything and send out evaluations around 7:25 to 7:30. Before we start, we're going to go ahead and go over a few etiquettes for a Zoom meeting today. So please mute yourself upon entering the Zoom call. If you need to speak, kindly unmute. You can press *6 to unmute yourself and *9 to raise your hand if you're using a phone. We kindly ask that you add your organization to your name and hover over your name in the participant box if you need to rename. It's kind of right down there in the little corner. Feel free to use the chat box throughout the meeting and join us by video if you can. I'm also going to add that if you can reserve all your Q&A, and we'll try and get to that at the end of the session, at the end of the breakout sessions as well. So today we're talking about after ACEs screening, early intervention and overcoming referral barriers, and Dr. Antonio will be speaking to us today. Dr. Carlo DeAntonio is a pediatrician and the Director of Clinical Services at the North Los Angeles County Regional Center. He earned his Bachelor of Arts at Harvard University and his medical doctorate at UCLA. He completed his residency in pediatrics at Medill Children's Hospital at UCLA. He's a past fellow of the California Healthcare Foundation Healthcare Leadership Program. His areas of interest include developmental disabilities, early intervention, and child advocacy. Dr. Antonio, let's have fun.
So thank you very much, Adwa, for the introduction. And well, tonight we're going to continue the series with talking specifically about after you've done the ACEs screening in your practice and some strategies that we can look at to provide intervention for children. And in this session, we're going to be specifically talking about young children 0 to 3. So we're going to have a kind of a focused discussion on that specific age group and resources available to them. So in the objectives for tonight, we're going to talk a little bit about generally the AAP guidelines for developmental screening, AAP meaning the American Academy of Pediatrics, and to understand that ACEs screening and developmental screening are not different things. It's part of the same kind of spectrum of developmental surveillance and screening as part of a strategy of well child care. And we're going to talk about early intervention also as a strategy for addressing ACEs in young children under the age of 3, and how to refer those children to California's Early Start Program and Regional Center. And also, we're going to touch a little bit on how the pandemic has impacted on screening and referral for young children, and talk a little bit in specific in the breakout groups, talking about barriers to implementing screening and referrals in clinical practice. So, the presentation is going to be mixed between having some lecturing with me in the beginning, and then there's going to be breakout groups and participation. And when we're talking about overcoming barriers, I don't specifically have an answer to overcome barriers, so that's something that we're going to develop in the breakout groups with the participation from everybody, and strategies that folks can share with their colleagues about strategies that they might have found effective to overcome some of the challenges that we experience. So we'll be expecting some active participation later on this evening. So getting started, I just briefly to recap the first couple of sessions of our ACEs series, that we had our first presentation with Dr. Christine Thang, and she talked about, in general, about the neurodevelopmental consequences of traumatic stress and the ACEs scores. And then the second session last month was Dr. Adam Schickendance talked about health system barriers and practice readiness to deliver trauma-informed care. And these slides are just some of the slides from the highlight slides, some of the pretty highlight slides from the prior sessions, and you know, talking about basically how early childhood experiences and adverse experiences in young childhood have lifetime effects. And there's a neurobiological basis for the impact of toxic stress and other childhood adverse experiences that have physiological impacts on the developing child and can lead to long-term issues throughout an individual's life. And that's the importance of this early identification and intervention in these situations. Children are very resilient, but at the same time, that resiliency can be frayed, and you can have those developmental and psychodynamic concerns in early childhood. And tonight, what we're really focusing on this, when we're looking at the course of life and talking about what happens in early childhood affecting all of adult life, in this talk tonight, we're going to talk about these little ones here. So we're going to focus really on the little children in this talk, and talking about those developmental issues in those young children. So we introduced in the prior presentations the concept of screening for ACEs, and through the ACEs Aware website have a lot of information about how to implement screening in your practice, and screening looking at abuse, neglect, childhood challenges, and toxic stress situations in a home for a variety of factors. And there's links there to familiarize yourself further from the ACEs Aware website. And also introduced in the prior talks is the screening tool that is recommended through ACEs Aware in terms of the Pearl screening tool. And that screening tool is a reimbursable screening tool as well when implemented as part of well child care. So moving on, we see that in addition to recap, we're talking about when you have the ACEs screening, you develop an ACEs score, and based on the outcome of your screening, you might provide different strategies. So tonight, we're going to be focusing on those young children, and we're also going to focus on those referrals that you might make when you're having a high risk score or other concern about a child's development. So that kind of sets the stage from the prior information about ACEs that was introduced previously. And moving on to after you've done that screening, after you've introduced concerns or issues in a pediatric patient in practice, what we do next. And I really want to specifically focus on early intervention, because the point is that ACEs are very much associated with developmental delay. So, and both screening for ACEs and screening for developmental issues and developmental surveillance are part of pediatric well child care, and they're both reimbursable. They're both reimbursable components that you can do in well child care. And when you look at the health, when you look at the health impacts, the associated conditions that are associated, the health conditions that are associated with ACEs, we see that developmental delays, learning problems, or behavioral problems are very strongly associated with significant ACE scores. So if you're identifying a high ACE situation, or you identifying your ACEs screening significant concerns, it is very likely that that child is also going to have some form of developmental concern or developmental delay. So the take-home message to stress is that ACEs situations where you're having high ACEs score is also strongly associated with developmental problems in young children. And And when we look at developmental delays and screening for developmental delays, you know, there are concerns that many primary care providers they might do some developmental surveillance, they might, you know, ask about development, but they're not really implementing formal screenings in practice. And the importance of engaging in formal developmental screening in addition to identifying ACEs is very important in practice. And as we see in this other image, that adverse childhood experiences occur, and as you see, disrupted neurodevelopment and social, emotional, and cognitive impairment are part of the pyramid of impact that we see in ACEs exposed children. And so in general, early intervention is a smart investment for children. When we invest in the early childhood, we get lasting impact in development. We all know in all the information about autism, having early intervention with autism to engage in, you know, for example, behavioral techniques in autism, the earlier that started, the more lasting benefit you're going to have in changing a child's developmental trajectory. So we're probably familiar with the fact that the American Academy of Pediatrics has produced guidelines that have been reaffirmed several times regarding developmental screening as a component of well child care. And they have specific intervals where it's recommended in terms of 9-month, 18-month, or 24 or 30-month general developmental, and also autism specific screening. So some people ask, some pediatric practices, why should I screen? I mean, I always ask people, you know, how are you doing? How's the little one doing in their development? And the parents say, tell me if there's a problem. That's kind of a common way that many people approach this, but it's found that when a formal screening with a standardized screening tool is implemented, is a much higher percentage of developmental delays and disabilities are identified than more informal developmental surveillance. And some of the common screening tests that we commonly see in pediatric practice include screenings like the Ages and Stages questionnaire. That's very popularly used. And then when we're looking at autism, the MCHAT is also very popular. Of course, the PEARLS for ACEs specifically, and also in looking at the social emotional component, the Ages and Stages questionnaire also has a social emotional module as well. And so these are all very popular screening tools that are used in practice. And so the general well child care recommendation in terms of the AAP guidelines are to perform developmental surveillance through well child care, autism specific screening at certain intervals in addition to general developmental screening. And then also we're in the recommendation of performing a ACEs type screening as well using the PEARLS tool. So you've done these screenings, and we're talking about the 0 to 3 children. And so how do you refer these children, or what resources are available to refer? So I want to specifically talk about the California Early Start program. And the reason why I want to focus that for the 0 to 3 child is that it's a very comprehensive program that's available throughout all of California. And the resources that are available through Early Start is geared to address developmental concerns, but it can also effectively address some of the concerns that would be expressed in a high ACEs score situation. So we'll move on and talk a little bit about regional centers. So it's a resource for developmental evaluation. It's a resource for early intervention, and also diagnostic evaluations for developmental disabilities such as autism or intellectual disability. They have an Early Start program as well as a lifelong program for people with diagnosed developmental disabilities. So we're talking tonight mostly on Early Start, but I just wanted to familiarize everybody with the fact that there's 21 regional centers in the state of California, and there's 7 alone in Los Angeles County. So it's a big system. It serves probably 300,000 people in California, and it's, you know, it will cover every part of LA County through the different regional centers there. But you know, we've seen, unfortunately, during the pandemic, and I'm sure you've all experienced this in practice, is there's been a significant impact of the pandemic on referrals to early intervention programs. It's thought that a lot of this is due to the fact that a lot of families have, especially in the spring of last year, spring and summer of last year, put well child care on hold. So there people, due to fear of the virus and because of the pandemic issues and staying at home, have not been bringing their children to well child visits according to the recommended intervals. And if they're not going to well child visits, they're getting fewer opportunities for that developmental surveillance and screening. There's also been closures of schools and daycares, um, and more people are keeping their kids at home, for example. But when you keep the kids at home, especially for young parents, they might not have as many social opportunities with young children to compare how their child's development's doing. We often find that a lot of times parents become concerned because they've had a play date with another child and they notice a difference between another child of their same age. So without these opportunities, without regular daycare or other professional surveillance of a lot of our young children, and also with the increase of stress related to job loss, maybe marital stress or partner violence that we've seen increases of during the pandemic, there may be more significant issues regarding developmental concerns and ACEs type concerns, but these aren't being identified. So, for example, in California's early intervention program, there was a significant decline in referrals for early intervention through especially April, May, and June, especially April and May of 2020. So, for example, at the regional center that I'm associated with, North LA County, we saw about a 50% or so decrease in referrals during those months. We get probably like 400 referrals for early intervention a month, and we were in the hundreds for those months. So it was a really dramatic decline. Fortunately, it's coming back up in terms of referrals. We're almost at our we're at our pre-pandemic numbers now, but the issue is there's probably a significant amount of catch-up of children who's missed their developmental screenings during that time. So this is something to be even more aware of in terms of pediatric practice, because there's a lot of children that have been missed and miss these windows of opportunity to participate in early intervention because of missed referrals, because of not going to well child care in a timely fashion. So specifically on the Early Start program, it's a program for children 0 to 3 that have either an established risk condition or a significant delay in one of their developmental domains. And the developmental domains that we look at in terms of cognitive, motor, language, etc., these are often things that a child with a high ACE score will also show these developmental delays, the language delays, social emotional delays, etc. Our program, we evaluate a lot of children that come from the DCFS system and from Child Protective Services, and there's a significant number of these children that have no other risk factors other than their exposure that led them to be part of a Department of Children and Family Services, and they have developmental delays. So there is definitely that association between these adverse childhood experiences and developmental delays. And also there's some, if a child doesn't have delays, there's some risk factors that can specifically make somebody eligible for an early intervention program, such as prenatal substance abuse, non-accidental trauma, failure to thrive, a parent who's developmentally disabled. So even if a child's not exhibiting delay, if they have certain risk factors, they may be able to qualify for an early intervention program. Now, a high ACE score in and of itself is not in and of itself a factor that in and of itself could qualify for somebody for early intervention the way the regulations are written. But my point is these children have so many other co-occurring conditions that likely some of these other conditions will qualify them, especially the delays that they frequently exhibit. And then if you're referring to child for early intervention, it's important to know that those children, the regional centers have a statutory timeline of 45 days from referral to determine eligibility for the program. So, and then how are they assessed? The regional centers, they actually perform direct assessment in terms of developmental assessment. So we talked about developmental surveillance and screening using a screening tool, but when we're assessing for delays through an early start program, we're actually using a formal developmental assessment tool that's looking at all 5 areas of development, or if there's speech language concerns, with a licensed speech language pathologists, et cetera. So using qualified providers in the discipline, so they're very complete and thorough assessments. So I don't want to spend too much time on this. I have these slides are in the packet more for reference because they're kind of extraneous to the program. But just to emphasize, when we're talking about early intervention, it's a 0 to 3 program. So that's again why the time is so important to get those children identified and referred. You don't have to diagnose them with anything. If you're concerned about the child, they just need to be referred because they will be assessed. And if they're referred prior to the age 3, then they could likely participate in early intervention until the age of 3. After the age of 3, the child to receive services from regional center has to have a diagnosed developmental disability such as autism or intellectual disability. But under 3, they don't have to have that diagnosis, just a concern regarding delay for an assessment. So I don't want to spend more time on this because it's kind of extraneous to our topic, but it's important to know once someone is in early intervention, what types of services would be appropriate. So if they have developmental delays, a program design is put together that would have services such as speech therapy, child development, et cetera. But also some of these services include can include parent education, parent support groups. There are some instances where if the issue related to the child's if the parents' issues are impacting their ability for the child to receive early intervention, there could be some therapy or counseling services for the parent as well included in early intervention. So it really depends on a case-by-case basis, but there's pretty extensive programming that's available that these families can take advantage of that can address many of the issues that we see in these situations. So, so now we talked about identification, we talked about screening, surveillance, and we talked about referrals to the California Early Start Program. And then we want to also talk about the barriers that people, the barriers that providers might face in terms of getting those referrals done and the problems that providers might experience. So if and this is kind of to kind of set the stage for our breakout groups and our discussions that are going to follow, and about the barriers that we see in our everyday practice. Many times we hear about barriers from the families themselves or from the parents that they'll take the information, they're not really interested in following up, or it's too complicated for them, or the family might have issues following through with referral or figuring out if how to get the referral done, or they having trouble getting through to the referral source, et cetera, et cetera. There may be barriers in terms of your practice, in terms of not having time to implement this and have the time to refer people, or maybe your practice doesn't have knowledge about what resources are available in the area. It's really confusing. There's no real centralized source to figure out where to refer children for these types of issues. You might not be familiar with providers in your particular area, or the providers you are familiar with are too far away. So there could be those issues in terms of how to implement that in practice. And there's issues with the resources themselves. Maybe the resources you're referring to are not responsive. Maybe they don't have any openings. Maybe they don't have resources in the language that your community serves or whatnot. So you could be frustrated by the resources that are available. They're not enough, or they're too hard to access. And then additionally, there's barriers that we're seeing because of the pandemic. Families don't want to do an in-person service, or an in-person service isn't possible in these situations, or they'd rather not do that. So those are some of the issues that we're going to explore tonight in the discussion. So this is kind of to get everybody's thought process flowing about things that they're going to want to talk about a little later on this evening in the discussion groups. And through the LA Department of Public Health, in terms of surveying practices on barriers in screening and referrals, the respondents identified some of these causes, which I just went over. parents are hesitant about it, or they don't want to do it. They're not sure who actually does the services. They don't have time. They don't even know how to refer, what phone number you call, how that even works, or they don't have enough staff to do it. So these are some of the things that practices are experiencing. So I hope we'll be able to discuss them in more detail tonight. And then also, First 5 LA has looked at these issues in terms of how are early intervention services. We have these wonderful services out there, but people can't be linked to them. It's too complicated. There's 7 regional centers in LA County. They all kind of do things a little bit differently. Can't really figure out how to get a referral through, or maybe there's it's hard to get through to the program. And also other resources for children, parenting classes, those other resources. It's not really a centralized way of knowing about those things. So for example, I'm up in the I'm in the San Fernando Valley area, and I might know a great resource that's in Northridge, but that's not going to be much help for somebody whose practice is in Long Beach, right? And how do you know where to go, or where to send a family to? Um, so 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 I think there's those are some of the systemic challenges of how to make the the network of services for young children less fragmented, and able to be accessible to a lot different people across the county. And some of the recommendations from that First 5 LA and American Academy of Pediatrics had a strategic forum on these issues, and some of the recommendations that came up with were things like having collaboration and coordination throughout the systems, better use of technology, and better communication between maybe referral sources and providers. And have a more family-centered focus in terms of how to identify needs and communicate between the provider or the medical home and the referral sources, and getting feedback from referral sources in terms of maybe early intervention programs and the pediatric practice. So, well, it looks like we've come close to the end. I think we were going to hold questions for the end of the session, and we wanted to kind of move into our breakouts first, so we have plenty of time for those breakouts. I might have finished a little bit earlier than on schedule by just a couple minutes, but that's fine because I think we have a lot of time for discussion. In terms of the breakouts, like I said, this is a participation-focused evening, and I think everybody knows what the problems are about these things. So we want to spend our time in the breakouts talking about solutions and sharing information that might be useful to the peers. So how we're going to do the breakouts is we've kind of organized our groups for tonight in different, oriented around some of the different barriers, the common barriers that we've identified, and having each separate breakout group be kind of tasked with looking at one of those particular barriers, and the facilitators of those groups will kind of lead the discussion on those. And then the goal is to have those discussions. Maybe you guys will come up with some great ideas. Maybe there's something that you've done in your clinical practice that has been really effective in terms of a strategy for improving referrals, or working with families to getting referred to early intervention or other types of referral programs, and share them with the group. So the idea is to have that peer-to-peer interaction, so people are talking about how they've successfully implemented some of these things. But or maybe that there's an issue that needs to be addressed at a policy level, where this is hosted by First 5 LA. We have our First 5 LA representatives here, and these are issues that can be taken back and brought towards more policy discussions about what might be needed to change the landscape of early childhood care in California, and specifically Los Angeles County. So looking at what policy objectives that you would want to see, and successes or that you've done, or would you like to do if you had the resources to do so. So those are some of the objectives of tonight. And so, like I said, so the breakout groups are going to focus in the family level, themes such as issues with follow through due to hesitation that maybe families have. Maybe there's stigma, maybe there's culturally related issues that certain families have. Maybe some families, because they're dealing with food insecurity, have other priorities in their lives other than worrying about the fact that their child isn't talking too much. Maybe that's not high up on that family's priority list. Or maybe some families are in denial. They think, hey, there's nothing wrong going on here. I think my child's fine. My brother didn't talk until he was older and he turned out just fine. So why should I worry that my child has a speech delay? So those are things that might be going on. Also, from the provider, maybe you don't have the staff or knowledge in the practice, or maybe there's issues with your resources or challenges related to the pandemic, and I touched on these things earlier. So those are the themes that we'll be talking about in the groups, and kind of developing solutions, not just talking about the problems. It's going to be about developing solutions. And so when we're coming back to the main topic, we want to talk about solutions and talking about resources that you might need in your practice to make these solutions possible. So, and then we're going to have a report out, and what we're going to do is we need probably for each group, we're going to have a volunteer assigned to be the person who is going to do the report out, so they can report out to the group, and we'll have a discussion then. So terrific. Well, we're not done yet, so I'm not going to put that slide up, but in this slide deck that will be in the resources that are available, there's lots of resources as well that everyone can look at on their own time, in terms of resources for screening, referral, as well as citations and other resources that you might find useful for learning more about these subjects. So I think we're ready then to move into the breakouts. Is that correct, Tomas? Are we ready?
Yes, we are ready. Just a heads up for everyone. You will see a pop-up on your screen with a 2-minute remaining alert. And then the 1 minute is going to be a countdown. So during that 1 minute countdown, you do not need to exit. It will exit you automatically upon ending. That way you still have that full minute for discussion.
Welcome back, everyone. So we're going to go ahead and share what our thoughts and ideas and resources that we came up with, and we will go break room by break room, I believe. So we're going to start with break room 1. I don't know if you have a representative, that would be great.
That's the family level?
Oh, so that's
right.
me.
Yeah. Okay. So yeah, hi everyone. I'm Chris Kavanagh. I'm the administrative assistant for AAP Chapter 2. And in my group, we talked about, we identified what are the issues on the family level, such as, communication between parents, barriers such as not having the resources to consistently come back after referral to the clinic's office. We also talked about problems with just losing time during appointments. So we talked about what are ways we can make communication more streamlined, have the parents be on the same page, and also what are ways that we can provide the right network and appropriate resources for families who might not have access, or who might live in fear for reaching out to more services. And that may include undocumented communities, low income. So, we were thinking about what are those community centers? Are there anything maybe peer-to-peer programs can help with in terms of reaching out to family that need it? Even language barriers, what are some things that could be dealt with language barriers, because then that affects how information is communicated in the exam room. So yeah, those are just some of the things we talked about. Feel free to add anything. I know that it was a very fruitful conversation, but yeah. So.
Thank you, Chris. I'll go ahead and speak for my group because I just realized that I didn't assign anyone for speaking for the report out session. So we talked about members of the group came from varying practices. We had a group member that dealt with a lot of unaccompanied immigrant children, and one of the greatest barriers that they had was language, especially since children and families had multiple different languages. So how they had gone around that was that she talked about, having translating services. And we really love the idea of a health navigator. And how they were doing that was that they were partnering with undergrad students from universities and colleges nearby who were really motivated to do this work. And so they would assign a health navigator to a family, and that person will be their point person to navigate, the complex world of, moving over here. Also talked about working with school health and a mental health guide as well, and how they would meet and just kind of try and put resources together. But she also said that even with all these, it was still challenging trying to get through to services for a lot of the families that they encountered. Another participant talked about how sometimes parents are often in denial or unmotivated. They really cannot be bothered. And so talked about maybe having motivational interviewing as a skill, a core skill for providers, just to kind of get that buy-in from parents as we begin to have these conversations with them. And also brought up an interesting idea of maybe partnering with 211 to handle case management, maybe reimbursing 211 to actually do the case management for us with families. And then we also talked about one of our participants who's in private practice said, you know what, it would be really great if regional centers could assign a liaison to offices or districts or, designated areas. So there's this one point person that you always pick up the phone and speak to and get follow-ups from. And then we also talked about, the need for health and parental literacy, because a lot of the times the communication isn't going anywhere if parents do not really understand what you're trying to say. So consistent and repeated messaging is key. We explored other things such as collaborating with the schools to support us as we begin to speak to families about delays that children may have. Those are the only things that I remember. Please feel free to jump on from my group if I left anything out. Well, if not, we'll move on to provider level.
Hi, so that's my group. So if anyone else has anything to add, please feel free. So things that we talked about on the provider level, some of those barriers that are encountered would be hesitancy from the side of the physician, having limited resources, not having the time or capacity to do so. So some of the outcomes or potential ways to overcome it that we talked about was one, having your staff outside of the providers be trained in this. Some groups have done ACEs aware training with their staff, others have not. Another solution was, I guess I would summarize it as having some cultural sensitivity or awareness in these questions. This came up as many providers have noticed that, for whatever reason, whether the family is embarrassed or doesn't want to disclose some of this information or may not feel safe to do so, that they may put 0 on their pearls when in fact, after the relationship has been built with the pediatrician, that they know that, the answer is not actually 0. And then another one was informing the family. I'll refer to the family as the general public, right? Us as providers, we've gone all these trainings about ACEs and talks and whatnot, and why we're doing all this. But I think out in the general population, perhaps hasn't been as much about this. Yes, Nadine Burke-Harris has a lot of public relations and is on the news and media and whatnot, but that might not be targeting the population that has some mistrust or whatnot of this.
Thank you, Christine. Can we use someone from the pandemic breakout room?
Hello, my name is Neera Maduri. I'm also going to be reporting from the pandemic group. we actually had a really very rich conversation. So some of the challenges that our group members faced was really the significant drop in visits, well-child visits that happened during this pandemic. Some of the things that practices were doing was going through their patient lists and trying to see who needed to come in, and then making phone calls to encourage family members to come in, to encourage family members to schedule appointments and bring their child in. I think one of the things that was said that I felt like was so powerful is the importance of actually physically examining a child, because the telehealth can be done, but it just isn't the same. And I think the emphasis was the therapeutic effect of really just touching that baby when you're doing the physical exam, or that child. And also the fact that a lot, even if you make a referral for early intervention services through regional centers, most of those services were actually virtual. So it was a bit of a challenge for the families to really follow up on that. And it wasn't, a lot of the children just don't respond when they're under 3 to having virtual services. So most practices were seeing well visits in person, and they did do some telehealth. So telemedicine was one way to kind of overcome some of these barriers. And for some practices as well, there were more frequent newborn visits, since a lot of families who had newborn infants didn't have their extended family members with them for help. Their pediatrician was really their resource and their source of comfort. And so if they didn't come in person, many times they had many phone calls with their pediatricians as well. They also adjusted their practices by reducing the number of patients scheduled at one time. So many times, especially if a newborn was coming in for a well visit, that was the only patient scheduled at that time. They didn't utilize their waiting room just to avoid exposures. And trying to avoid having siblings and just one parent, one child in the room. Probably one of the things that was a good resource was actually the American Academy of Pediatrics, who really encouraged families to make sure and bring their children into for their vaccinations and their wellness visits. And then a lot of the practices in our group were being very accommodative. And even if the family didn't want to come in for an in-person visit because they were afraid, they would do vaccinations with the child in the car, just to minimize that exposure and that fear. Just trying to make sure. And the kids in those watershed years of being 4 to 6 and then 11, where you have required vaccinations for schools, practices were being very proactive to contact those families ahead of time to let them know that they have vaccines due. So to please schedule an appointment to come in. It was interesting because we had a variety of geographic locations. So for a practice that is in, for example, South Central Los Angeles, even if families made an appointment, just logistically, something would come up that was out of the family's control. So it was very difficult. Even if an appointment was confirmed, it was really difficult for those families to maintain their appointments, in spite of having a good office staff that was a good point of contact. And if anyone was in group 4, if you have anything else you want to add to the conversation. Okay.
Thank you, Nero. Now we'll go to our resources breakout room.
Okay, can you hear me? Can you hear me?
Yes.
A little
Yes.
low.
Just a little faint.
Let's see. Is this better?
Yes.
Okay. So the first thing we decided that we should, this is sort of a wish list, I guess. We need a better model of reimbursement. If we got paid what we were worth, we would do the screens, no doubt. We just need more time with our patients. We would do the screens. We could refer the patient to the referral source. There'd be lots of referral sources because everybody gets paid like they're supposed to. And we can do a good job helping these kids. So if we had that time, we would all be kind of on the same page because we would all be working together for the same goal. So we don't have that, obviously. So what is it that we want as providers to sort of close the loop? We need to know that the patient has had an intake and been accepted into the program. A diagnosis, if there is one, what kind of services our patient might be getting, and follow-up reports. And how do we get that? Maybe there could be sort of a referral portal where that information could be deposited and we could go check for it. And unfortunately, that also takes time. But one idea to overcome needing to put it into a referral portal would be that if a third party came and did evaluations in your office for a half day a week or something, if you screened and found something that needed to be done, you could just put them on that person's schedule and they'd be evaluated. And then the referral portal is kind of an issue because we have so many computer systems that need to be integrated and are just not. So not only would you have to be able to access someone else's computer system. Oh, and I forgot one thing. Parental consent would be really important. But if you could maybe have the patient to sign up or get referred while still at the office, that's another time and money issue. But somebody could actually do that for them. So they don't have to do the call later, however much they need to talk to the person accepting the patient referral is, I don't know, but I've been told that the parent actually has to ask for services. However, that doesn't mean they can't be helped. I think that's what I remember and from my scratchy notes. If anybody else has a comment, please feel free to hop in.
Yeah, this is Carlo. Excellent. I just wanted to say, when you talked about closing the loop, I think you just expressed that there's a real interest in that the referral to the early intervention resource is not like a black box. Like that's the barrier, is sometimes that early intervention source, you don't know what happens. And so, there's a way to have linkages between the referral sources and the providers, so that everybody's working together on the same page instead of having the siloed systems that we have now. So more integration between the practices and the referral sources.
Thank you. Anybody else?
Thank you, Stephanie, and thank you, Carlo. I think that at this point, we can go ahead and answer some questions. If people want to post them in the chat or mute and speak, feel free. It's a big group, so I can't see whose hand is raised, so just kind of jump in if you need to. We did have one question from earlier on, and I think it was from Stephanie. You had asked cause or effect, relationship between developmental delay and ACEs. I don't know if Dr. DeAntonio, if you want to take that. This is the chicken before the egg before the chicken.
It's the chicken and the egg. I think I think it might be hard to know. I mean, I think it's both, because for example, just from some anecdotal examples from real experience, like there's a situation where there was a very medically fragile child who had significant medical needs in home, medical technology needs, like a home vent dependence and all those things, and the amount of stress that generated for that family in terms of grief that their child was not you know, on developmental typical trajectory and the stress of the care and whatnot, that created a stress situation for that family and for those parents not being able to well cope for that. So, you know, sometimes you could say that the developmental issue with the child could be a source of the stress within the family. I mean, we've seen a lot of families that there's been divorce over the fact that there's a developmentally disabled child in the family. Just, you know, for example. So the disability can create stress in and of itself. But on the other hand, you know, you have those situations like a child abuse situation or abuse, you know, or other types of situations where exposure to domestic violence, and you're seeing the developmental outcomes or the developmental impacts of children who are not getting proper stimulation from, you know, parents that, you know, are having, you know, difficulty with attending to their child due to, you know, maybe their own mental health or substance abuse issues, et cetera. So, you know, that is, you could say that those stressors are causative of the developmental issue in the child. And in other situations, the developmental issue of the child might be causing the family stress in and of itself. So it's chicken and the egg. It could be both.
Thank you. Dr. Tan, Christine put in a very helpful resource for screening tools. I think all the screening tools that we need in our practices, it's all on one page through the AAP. Dr. Fine has a question. Carlo, does Regional Center pay for parent-child interaction therapy in kids with severe delay?
I don't, let's see. I mean, I'm not quite sure what specifically in terms of parent-child interaction therapy. I know that a lot of the early intervention programs for the young children include, you know, these child development programs, and that type of program, you know, there's a lot of parent training in those programs, and a lot of the, for example, like the behavioral programs, like ABA type programs, there's a huge component of parent training and parent teaching in those programs as part of those models. So I would say, you know, I can't say a specific program if a regional center pays for that, but most of the common early intervention services involve child development. They might involve parenting. They might involve you know, programs such as behavioral programs where the parents are very important participants in those interactions. So for early intervention, I would say those types of programs are typically funded through early intervention.
Thank you. Any other questions? Thoughts? Go ahead, please, Stephanie.
Thank you. So I was just thinking about what was mentioned earlier was that the parent says, oh, his dad talked late too, or whatever. I generally, you kind of have to know the family pretty well to do this, but I generally like to have some idea of what, you know, like if dad spoke late, did he actually graduate high school? And, you know, you can go by saying, you know, he talks fine now, that's great. But I wonder if he'd been able to get a little bit of help early on. Maybe he would have done, you know, gotten straight A's in high school. You really don't know. So my job is to help the kid do the best that he or she can. And that kind of takes it down to more of a, I think something's wrong, to, I think there might be something we can do to help, you know, to accelerate. I like that.
I think that's a very nice way to frame that, right? What could have been, right? Did the parent get everything that they needed to get to flourish? We don't know that, but our role here is to make sure that our patients flourish, right? So it's always that balance of trying to get that information from the families. Thank you for saying that, Dr. Booth. And then we have a question from Anaga Suresh. How does the transition from regional center to school district services happen post age 3? Do parents need to initiate this?
Right, that's a great question. And I think that probably one of the most important reasons for children to be referred to early intervention for 0 to 3 is that they get a very smooth transition to the school district for early preschool. So, even if a child is in early start and they're not maybe receiving other services because they're covered through health insurance, like speech therapy or something like that is covered by the health insurance, the regional centers can really help with that transition. It should be done automatically. So usually around 2 years, 9 months, the regional centers, the early intervention staff usually they have regular meetings with the school districts. Like, for example, just at North LA County Regional Center, the LAUSD representatives were on site so much that people thought they were employees. They like were at our offices, and they met like 5 days a week, all day, with family after family to do those transitions. So the regional center usually initiates it automatically as part of their transition planning when that child finishes the early start program. So some children that finish early start, they don't have a developmental disability, they just have a speech delay, and they'll be transitioned to school. Other children that are in early intervention program, they might have autism, and that's why they've been so delayed in their language. They might have autism, they still get transitioned to the school, and they also get to continue with regional center after 3. So it should be an automatic process.
Thank you so much. So I think that was the last question, and we have to wrap up. I want to say thank you to everyone for staying with us through all this. And I don't know about you, but I think we need to have Dr. DeAntonio on pocket dial for everything related to early intervention. That would be amazing. So something to consider, First 5 LA. But thank you so much for the wonderful presentation, and thank you all for your contributions and sharing what you've been doing in your various practices. I'll hand over to, I don't know, maybe myself, Thomas?
Me.
Yeah, there you go.
Thank you so much, Dr. Jose. And so I want to thank everybody again on behalf of AAP Chapter 2, our ACEs Aware Committee, and First 5 LA. Thank you so much for joining us this evening and engaging in some really wonderful conversation. As you may know, this series is funded by ACEs Aware, is a part of a statewide initiative, and we will need to report some participant feedback. So we greatly appreciate if you can complete the survey, which is linked here. It's also been dropped in the chat. You will also receive a follow-up email. So various ways for you to access this link after this evening. Also note, if you are obtaining a CME credit, you're also required to complete the survey, please. Next slide. And we invite you to join us for our next and final session in this series, which will take place on April 22nd. Dr. Maduri and Dr. Jose will be presenting on the impact of secondary trauma and burnout with a blueprint for wellness. We will also be, thank you, Anne. Drop the link for you in the chat, and also available in this handout, and will be emailed to you afterwards. So thank you again. Have a wonderful evening. Good night.
Thank you.
Good night. Thank you.
Good night.